Good evening, this is Rob, and I'm giving a presentation on a patient that I saw in the clinic last week. It's a 70-year-old patient 70-year-old male patient that came in with worsening shortness of breath and cough. He reports that he has had this shortness of breath with a cough for several years. He said he got an inhaler several years ago, and he's never really had a diagnosis that he remembers, but he's finding that the albuterol isn't really helping as well as it used to within the last month. He reports that the shortness of breath gets worse with exertion, improves with rest. The albuterol sometimes helps, but sometimes it doesn't. And then he reports that the sputum is a white-colored sputum. Has a past medical history of hyperlipidemia and hypertension. His hospitalization and surgical history is not significant or relevant to this case, and he has no psychological history. He is up to date on his preventative care. He's received the flu shot this year. He's fully COVID vaccinated, and he's also gotten the pneumonia shots. He has no allergies to any environmental, food, or drug triggers. And his medications, he takes atorvastatin 40 milligrams. At bedtime, he takes losartan 20 milligrams twice a day. And then he takes hydrochlorothiazide 25 milligrams in the morning, and then the albuterol inhaler, 2 puffs as needed every 4 hours for shortness of breath. He has a significant family history that's relevant to this case. His mother died at age 65 of lung cancer, and his father died at 75 from COPD. Also had a significant smoking history, but the patient isn't aware of just how much he smoked per day. The patient himself has a significant history of tobacco use, 25-pack year history, and is still currently smoking 2.5 packs per day. He does drink 3 to 4 alcoholic beverages per week and denies any illicit or marijuana drug use. Review of systems. Constitutionally, he denies any fever. He does report fatigue and unintentional weight loss of 10 pounds in the last month. He also reports, he denies dizziness, heart palpitations, and chest pain, but he does report shortness of breath, orthopnea, and exercise-induced shortness of breath. He denies any wheezes. He does report a productive cough of white sputum. Vital signs are heart rate 73, blood pressure 128/75, temperature 98.4, O2 status 94% on room air, respiratory rate is 20 to 22 per minute. He has no pain, and his BMI is 29.4. Physical exam reveals a general survey. He's sitting in a chair. He's got a very long expiratory phase to his respirations with pursed lips breathing. And then he's awake, alert, and oriented. He has good cognition, good reasoning. He's able to recall events both in the recent and the remote past accurately. And then he, cardiovascular wise, he's dusky, he's got some clubbing fingers, no cyanosis, he's got good pulses all around, he's got no jugular vein distension, his chest is symmetrical without any visible lesions or scars or masses. He has no heaves, thrills, or lifts on palpation. On auscultation, he's got S1, S2 without S3 and S4, no clicks or murmurs. His maximum point of input is at the mid-clavicular line at the 5th intercostal space. His respiratory reveals an AP ratio of 1:1. The chest is symmetrical without any visible scars, lesions, masses, or hematomas. His respiratory excursion is equal, but it is limited. And he has, upon auscultation, he has diminished bronchofascicular lung sounds. So diagnosis-wise, 3 diagnoses: emphysema, chronic bronchitis, and lung cancer. Those are my differentials. And so emphysema because of the barrel chest, the pursed lip long expiratory phase of breathing, the cyanotic, the dusky skin, diminished bronchofascicular lung sounds, and the smoking history. Chronic bronchitis because of the AP ratio, the pursed lip prolonged expiratory phase, and the protective cough of white sputum, and also the smoking history. Lung cancer because of the protective cough with 10-pound weight loss. The familial history is also significant for lung cancer, so we need to kind of look at that and rule that out. So our plan is to get a chest x-ray, and then of course if we see any nodules that are greater than 6 millimeters, we're going to send him for a CT of the chest. And then we want to get a CBC and a CMP. Education-wise, the number one thing he could do to prolong his life and improve the quality is to quit smoking. So we gave him information on the Florida Quit line. It's a program paid for from the taxation of smoking products that gives patients 4 counseling sessions, nicotine replacement products for a month, and an educational course to help them to quit smoking. And then treatment is going to be with ipratropium, 34 micrograms, 2 inhalations every 6 hours as needed for shortness of breath. I instructed him to take the albuterol first, and if that doesn't work, then to take the ipratropium. Referral for pulmonology. We don't have lung function testing equipment at our office, and so we need to have a better understanding of his disease process, so we're going to send him for pulmonary evaluation and initial management. And then follow up in 1 month to review that chest x-ray and labs. I instructed him that if he has severe shortness of breath, after using the ipratropium and the albuterol, he doesn't get any relief, he should go to the emergency room. And if he has cyanotic lips, he should call 911. And that's the end of my presentation. I hope you have a good day.